All right, just some definitions again. Antibiotic is any substance that kills microorganism growth or prevents the growth. We define pathogen as anything that is an organism that is causing diseases in some fashion. The term empiric is an interesting one. It's basically therapy that is instituted without really knowing specifics, but just kind of as a general rule. So for instance, if I have somebody come in with a community-acquired pneumonia, the chances are it's a streptococcal in nature. That's just the most prevalent type of pneumonia that you end up seeing. So we would start a drug that is specific for that type of pneumonia, not knowing for sure that it's it, but it's a good chance that it probably is. That's called an empiric decision. Okay, it's based on a history and just what we would typically do in that case. We know what normal flora is. If you've had micro, we all have. And the difference between aerobic and anaerobic organisms. The process by which we identify the gram-positive or gram-negative status is called a gram stain. I'm sure you all did that when you were in micro. And along with that gram stain, we can also do a culture and sensitivity. Specifically, we're talking about blood or sputum, something along that line. And what that allows us to do is identify which specific antibiotic this specific strain that we're growing is susceptible to. And then the difference between bacteriostatic and bactericidal. Static just inhibits further growth, doesn't kill the bacteria, where bactericidal does. And then we talk about broad spectrum and narrow spectrum, and I'll come back and visit that again on another slide. But obviously, broad spectrum is going to cover a whole lot many more organisms than a narrow spectrum, which only covers certain organisms. Some of the more common gram-negative and gram-positive. Really, staph and strep are the two primary ones we end up finding as being infectious agents. The gram-negatives are always a little bit harder to kill and are a little more prevalent. Some of them are actually, well, yeah, let's leave it at that. I'm not going to test you on the different types of antibacterials that are there, the penicillins, the vancomycins, the erythromycins, the quinolones, because they're a little bit too much and it's a little bit out of our scope of practice. Just knowing there's a couple of antibiotics that we have to be aware of because they're ones that are nebulized. And here's an example of some broad spectrum versus some narrow spectrum that are used to treat specific organisms, where some of the broad spectrums can be used pretty much on a lot of different things because they kill a lot of different things. This is the different ways that the antibiotics work. Again, I'm not going to ask you this, but this is just out of your text to talk about whether it's inhibiting protein synthesis, whether it's destroying nucleic acids. There's different ways that the organism can be eradicated. This is the classes of antibacterials I mentioned about. Basically, each generation of antibiotic that has been created is better than the one before and covers more specific organisms in the process. And here's some examples of the ones that we talk about. We're going to focus on tobramycin because that's one that is an inhaled medication. The other one I want, or the other two, vancomycin for methicillin-resistant Staphylococcus aureus. I think you probably had that last semester, talking about some of the difficult ones to kill. And C. diff is another one that is a very difficult organism to eradicate. And, there's a bunch of them out there, though. The drug that we're going to focus on, one of the first of the two of them, is tobramycin. And tobramycin is a drug which is used because of chronic Pseudomonas infections in cystic fibrosis patients. they're pretty much on a regimen of this medication. Trade name is Toby. Isn't that cute? Toby. The dose is 300 milligrams, which is 5 milliliters of solution that is nebulized. It's all in the unit dose, so you don't have to worry much about mixing it up. And we do it twice a day, and it's basically 28 days on, and then we give them 28 days rest, and they're back on it again. So this is a chronic medication that these people take. It is a very viscous solution, so traditional nebulizers don't work really well with it, and I'll talk about that in a second. And because bronchospasm can be a side effect, it is something which is basically we pre-bronchodilate them with albuterol prior to the therapy. This is the Pari LC Plus nebulizer, which is the nebulizer that is used, and we use it with a whole lot higher flow rate than we would use with a conventional nebulizer. Conventional nebulizers, 6 to 8 liters per minute. Here we're using it with a bit higher level because it's such a viscous material that it requires that higher of a nebulization. The second antibiotic that you might encounter is colistin, and it's an alternative to Toby in those strains of Pseudomonas that are resistant to it. It's from a group of antibiotics called the polymyxins, and there's one specifically that we talk about, polymyxin B. This is kind of a weird drug. It comes as a powder and needs to be reconstituted. Typically that's done by pharmacy, so it's not as much of an issue. And like Toby, it can cause bronchospasm, and you can see the dosage there. I believe this is one of the drugs that'll be on the test for you to spit back. Again, I would never expect you to memorize this, but recognize that there are some disease states that have suspected pathogens, and empirically we would start with these antimicrobials. So a community-acquired pneumonia probably is going to be streptococcus, and we would have some specific antibiotics that would go along with that. Yeah. Again, I don't expect you to memorize this, but recognize that certain ones do have certain uses. Those are all bacteria. Well, what about the other microorganisms that are out there? Well, how about viruses? We know viruses, by their nature, are obligate parasites. They can't live, at least not for long periods of time, without having a host. And if you kill the organism, you always have the chance of killing you in the process. So we got to be careful with antiviral agents. We can divide viruses into RNA and DNA viruses. The RNA viruses are the ones we probably encounter a little bit more. The DNA viruses are the ones that are there also, but again, as far as we're concerned, we don't encounter those. But influenza, certainly, polio, HIV, encephalitis, those are all things we may encounter in the process. There's a specific antiviral agent we talked about previously called ribavirin. It used to be used to treat respiratory syncytial virus. It still is utilized for some viral infections in patients that are immunocompromised, like going for a bone marrow transplant. The other antiprotozoal agent, and this is really strange. Remember, protozoa are the ones that are kind of prehistoric microorganisms, and the specific organism is Pneumocystis carinii, or it's now got a new name, Pneumocystis jirovecii, after the guy who first described it. And it's a type of pneumonia that is present in patients that are immunocompromised. Specifically, we see it frequently in patients with HIV. And I'll talk about both those in a sec. Let's talk about ribavirin first. You should know the trade name is Virasol, and we talked about it being used with that SPAG nebulizer. Now we don't really use it for that purpose. Here's your SPAG, Yahoo. Ribavirin is nasty. I mean, carcinogenic, teratogenic, embryocidal. That doesn't sound like a real good medication to be nebulizing. And obviously, pregnant women or women thinking should be becoming pregnant should not be in the environment where this is being nebulized. As of right now, it's not a recommendation to be used with RSV due to bronchiolitis unless these criterion are there. And we will find as we talk about patients who are long-term, who are born prematurely and have long-term either cardiac or pulmonary defects subsequent to it, that they would be candidates if they did develop an RSV infection to have ribavirin there. So other than that, we won't worry about it. There is an IV medication which is given for respiratory syncytial virus. It's called Respigam. Since it's administered IV, that's all I want you to know about it, that there is a medication out there which has been FDA approved for that purpose. Really, most of the stuff we do is just supportive care. It's even questionable whether albuterol is indicated. I know it's shocking, but they recommend a brief trial of it. If it doesn't seem to work after giving them a treatment, certainly do not continue on doing it, because it doesn't. These are the bronchioles, and there's not as you don't get as much response from it as you do, say with an asthmatic patient. We see RSV. This is the point in time where we're coming close to the end of the season, but it starts usually late October, early November, and runs through March, and we'll see a lot of cases coming in through the ER. And obviously, this is one that is very easily spread just by simple contact, so we need to make sure hand washing is effective. And here's some common antiviral agents. Tamiflu, you may have heard of, Relenza, both of which are used commonly for the influenza vaccines. This season has kind of been a different season than prior influenza seasons. 1, 2, 3 years ago was affecting mainly young females. So we had a lot of patients on ventilators who were 25 years old and were very, very sick. But this season hasn't been quite that way. And if we haven't talked about it, one of the things that'll happen in the fall is you will be required to get the flu vaccine, which I know everybody loves to get because all the bad kind of things happen and you develop Guillain-Barré syndrome and you die. But none of the clinical sites will take students without them having the flu vaccine. So there you go. So the other drug that is there, as we talked about, was Pentamidine. And Pentamidine has a specific organism that it treats. Whether or not this is a protozoan or a virus is still debating, but doesn't make a difference. This is again a dry powder that needs to be reconstituted. You guys all know what I mean by a reconstitution, do you? Yes? Comes in a vial as a powder. I take some sterile water, squirt it in, shake it up, and it's now reconstituted. And from that, then I go ahead and I inject 6 milliliters to be nebulized. And it has a specific nebulizer also, the Respirguard 2, which has the ability to filter the exhaled gas so it's not released into the atmosphere. We talked about bacterium, we talked about protozoa, we talked about viruses. What about fungi? That's why we eat mushrooms, because we're a fun guy. But fungi include mushrooms, yeast, and molds. We see them a lot in patients that are immunocompromised. Goes everything from simple things like athlete's foot through some really bizarre inhaled pneumonias. Histoplasmosis capsulatum is found from dried bird droppings. So somebody who perhaps works in a chicken egg factory. They have all kind of problems with that. Candida albicans is oral candidiasis or oral thrush is what we see developing if we don't rinse the mouth properly from inhaled corticosteroids. But there's some really wild ones. Aspergillosis, I worked in a hospital where the ICU was closed down because they kept culturing aspergillosis, and it's like, that's a weird one to have. But you have a wet environment, you know, it was actually in the plumbing system where it was coming from. The primary drug I want you to know for this is amphotericin B. It's not something that it's given, it's an inhalational drug, but it is something which is given as an IV agent. So amphotericin B is used for antifungal. It has been given experimentally off-label as an aerosol, but it's primarily as an IV. And it's a potent antifungal agent. It's got the nickname amphoterrible because it it just wreaks havoc. But it effectively does kill fungal infections. TB. And Jeannie will talk about tuberculosis and come back and visit these anti-tuberculin drugs again. But this is basically one where we have a primary drug that we use, our first-line drug, and then we have some secondary drugs we can use also. Typically, the medications, if you are involved in an exposure to tuberculosis and you test positive, you will be placed on one of these agents. For sure, isoniazid, but typically rifampin, pyrazinamide, ethambutol, rifabutin. Those are all anti-tuberculin drugs that you end up having. And there's a couple different approaches to these. One is a 9-month approach, one is a 6-month approach. In the case of the first one, it's just 2 drugs that are used. In the case of the 6-month approach, it's 4 drugs that are involved. There's a big problem with tuberculosis in the population that are HIV infected. And one of the areas where we're seeing a real nasty strain come out are prisons. Because they're close together. Often they have HIV. So it's nasty, and this is where these drug-resistant strains of tuberculosis are being identified. In that group, the cure rate is very, very poor. I don't make mention of it. I think when Jeannie talks about these, she'll point out about how some of these drugs are, shall I say, not desirable to take. One of them you can't drink alcohol with, which, forget that. I'll die of tuberculosis instead. The other one makes oral contraceptives, it deactivates them. Another problem for ladies. Just saying. Lidocaine, we aerosolize with an atomizer prior to bronchoscopy to numb the back of the throat. There also is lidocaine, which is available as a jelly, which we'll put on the end of an endotracheal tube as we're intubating. And when we talk about chest tube insertion, there needs to be some anesthetic agent, obviously. If I'm going to poke a hole in your chest, it'd be nice to numb the area a little bit prior to that process. I don't expect you to know the dosages. I don't think I test you on this at all, other than the fact that it's something which is used as an anesthetic, topical anesthetic. I've actually seen it used also as an anesthetic prior to arterial punctures. To me, that's insanity. It's like, what, I'm going to poke you twice? Once for the anesthetic and once for the actual puncture? I don't know. Lastly, I just want to talk a little bit about nicotine replacement therapy. Any comprehensive smoking cessation program should have some nicotine replacement as a component of it. We know about how many people smoke. I forget what the percentage in Michigan is. I want to say it's like 20%. 1 in 5 people smoke. It's still higher than it. I mean, it's lower than it used to be, considerably. But yeah. Part of the problem is it has a high relapse rate. The smoking cessation rarely does occur on the first attempt. There is a test, and your text has it. I'm not going to ask anything about it, but but it's called the Fagerstrom test for nicotine dependence. And really, when we got them as a captive audience, that's a great time to get him to stop smoking. Most of the hospital, I think Mary covered this during orientation, but let me rephrase that, all the hospitals are non-smoking campus, so that means you have to physically go off campus to be able to smoke. Some of the larger health systems have instituted a policy that they do a urine screen on you and test for cotinine, which is a metabolite of nicotine, and if you test positive, they won't hire you. So, ew! We can give nicotine transdermally, so this would be something where we would have the patch. We can give it as a gum, we can use it as a nasal spray. Then there's two that aren't nicotine replacement. Those first groups are all, you're basically giving the patient nicotine. So they need to be reminded that if you're on nicotine patch, don't smoke, because you're double dosing yourself. The purpose is we'll gradually wean you off that nicotine dependence. Okay. So basically the way nicotine works is that there's certain receptor sites, nicotinic receptor sites, you guys know about those. They're cholinergic in nature. And they cause a lot of different effects. And it's the euphoria that is typically the feeling, the high that you get from inhaling nicotine. Although because of the carbon monoxide that's typically in there, you also have a reduction in cognitive performance. So it's kind of like, yeah, you're feeling a good buzz, but losing some brain cells. Two other ones that are out there that you should be aware of, because it could be things that we would recommend to patients. The first one, bupropion, Zyban, or Wellbutrin, is used quite frequently for ADHD and behavioral stuff. It's also used to treat massive depression, but it does reduce your urge to smoke. So it is one option that is out there. The one that you've probably seen on television, varincillin or Chantix, it blocks a specific nicotinic receptor in the brain, and within 10 to 20 seconds, it basically, normally nicotine would attach to this. This receptor in turn is what triggers dopamine, which gives us the pleasurable sensation of smoking a cigarette. Both formulas do contain nicotine. As far as the nicotine replacement, we talked about that. And hopefully the process would be using nicotine replacement, that it's weaned down as you go along, and within 3 months you're off. Caution should be made for us. The nicotine patch specifically, when the patch goes on, that patch has nicotine on it, and getting it on your fingers, you can absorb the nicotine in, and that may not be beneficial to you. Both varincillin, Chantix, and the other one have mood swings involved. Chantix probably more so. People talk about bizarre dreams, talk about suicidal ideations. It's a scary drug in one sense. Has anybody tried it? I'm speaking. Any issues? Okay.
My husband is taking it right now. He was real moody.
Yeah. It's short term. It's to get through that. The hardest part to quit smoking is in the first 5 to 10 days after you quit. So it's getting through that first 2 weeks that is really the focus. But this is basically showing how varincillin blocks that nicotinic receptor and prevents that release of dopamine and the euphoric feelings. I thought that was it. I guess there's a couple more here. How about methacholine? This is a cholinergic agent. The doses there, you don't need to know specifically the dose. Actually, what ends up happening is we create multiple doses of this at varying level or varying concentrations. So we start out with a very mild and get progressively greater. We use this for what is called a bronchoprovocation test. This is a test that we test for hypersensitive airways. If somebody has signs and symptoms of asthma, but their pulmonary function tests don't reflect it, this is a way that we induce bronchospasm. So we purposefully create a bronchospastic problem. This is a parasympathomimetic, okay? And this is, again, the examples we're going to end up using. Now, notice we're inducing bronchospasm on somebody. This can be a very life-threatening situation, so we want to make sure we're doing it under very close observation of the patient, and they will need, I don't know about metapaternal. I would think albuterol would be faster acting than that. But you need to have something available to administer once the test is completed and we've verified that they have reactive airways or they don't have. Ethyl alcohol, you probably will never see used as a nebulizer drug. Used to be used in the treatment of asthma, pulmonary edema, excuse me. When pulmonary edema, when the fluid moves out of the vascular space back into the alveoli, what ends up happening is you end up creating small bubbles. And this is where we get, when a patient in pulmonary edema, when they cough up pink frothy sputum. Well, it's basically that blood that has moved back across. As it moves from a liquid state to a gaseous state, it creates bubbles. Just like you do with a little bubble mixture that you would use. What the alcohol does is it breaks those bubbles up. Never been proven to work, but when we used to get patients in pulmonary edema, CHF, into the ER, we would give them alcohol treatments, and they felt better. They calmed down. But you're looking at a 40% solution, which is what, 80 proof? So a nice, good vodka down the tube. And we talked about surfactants previously. For right now, you don't need to know the doses, but those are the doses that we would end up using. So a very small amount of, if you got to have a child that's a kilo, 26 weeks, 4 milliliters, split between both lungs, you got it. And I'll stop there. Thank God. Written by a lawyer.